credits. We welcome you to another Sovah Health CME program. As you know, tonight we'll be talking about an update on esophageal disorders. This program tonight provides, so now I can't get into advance. There you go. The program this evening provides 1 hour of Category 1 AMA CME credit for physicians and 1 hour of Virginia Nurses Association CE credit for nurse practitioners. Sovah Health is accredited by the Medical Society of Virginia, which is a member of the Southern State CME Collaborative. And we are also accredited for nursing CE credit hours through the Virginia Nurses Association. The programs developed this evening to promote patient-centered care and to help us employ evidence-based medicine. The basis for the program this evening came from the annual medical staff's survey of needed topics to expand individual provider knowledge and competency, and for a number of publications in the past 12 to 18 months on new drug therapies for some of the esophageal disorders. Dr. Reddy, who is our speaker this evening, has reported one relationship to a commercial entity known as an ineligible company in the CME world. This is with Sanofi Pharmaceuticals, where he has been a member of their key opinion leaders panel. A mitigation plan to manage this relationship was agreed to with Dr. Reddy, including the CME office reviewing his slides for any evidence of commercial bias, and there are none. And then his attesting that any clinical recommendations he may make during the program will be evidence-based and will be free of any commercial bias, coming from peer-reviewed literature that adhere to evidence-based medicine consensus practice guidelines. Myself and members of the Sovah Health CME Committee have no relationships to report. There is no commercial support for the program this evening. It, like all of our Sovah Health CME programs, is supported by the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. Dr. Landis, who founded the Southside Urology Clinic, also known as the Danville Urologic Clinic, or DUC, if you're a local resident for some time. Dr. Landis founded the clinic, and upon his retirement in 1985, he made a generous donation to establish this fund, which provides medical education support for all types of healthcare workers in Southside Virginia. This evening, you'll receive a program evaluation by email and also through a QR code I'll tell you about in just a moment. We ask you to please take some time to fill it out. We take the evals very seriously. There are some 7 or more questions on the eval. Number 4 asks, what change are you planning to make in your practice based on what you learned this evening? And that is for everyone, not just the providers. We all practice our care for patients in our own scope of practice. So be sure and take a few minutes and share with us what you've taken away and how that may impact on what you do on a daily basis. That form, the evaluation form, will ask you to re-enter your name and your email. This is very important. Please give us your full name, not a nickname or a short name, in as much as that information is what's placed on your CME certificate. If someone is sharing your logon tonight, and they are welcome to view the program and participate, please let myself or Mary Kent know that so we can be sure they get credit for the program also. Mary has developed a process where in the chat box towards the end of the program, there will appear a QR code that you can snap on, click on, take a picture of. That will also take you to the eval forms if you prefer to use that method. Just to let the residents on the call know that you do not have to keep up with your CME certificates. Your program coordinator, Dara Johnson or Lori Galvez, track your participation in these programs and look after that for you. Otherwise, everyone else will receive a CME certificate per email based on the evaluation form. The evaluation form is totally voluntary to the physicians. However, for nurses and nurse practitioners to receive a CME certificate and credit, the Virginia Nurses Association does require you submit an evaluation form. If you have any questions about this process or the forms, etc., please reach out to one of us. Every time we do a program, I like to specifically thank Mary Ken and Jennifer Goodman for their help in our putting these programs together. They do the, if you will, heavy lifting that makes these programs possible with the documentation forms and numerous emails. I know Dr. Reddy is going to encourage questions. You're urged to do that. Probably one of the easiest ways to put it is to put it in a chat. Mary will then be monitoring that and bring it to his attention. You also can just speak up and that'll be fine. Once you've asked your question or given a comment, please mute your phone so we don't have feedback and we can hear the answer. You are more than welcome to ask more than one question, more than one comment. In fact, the more conversation we have, usually the better the program actually flows. I want to make you aware of 3 programs that will be coming up in September as we begin what might be called the fall CME season. We will have 3 programs on Serial Thursdays beginning on 9/11, September 11th. That evening, we'll have our annual oncology program, which this year will focus on esophageal and pancreatic cancers. There have been some new developments in the management of these very serious disorders, and our speakers will be bringing that information to you. The next program is a week later on Thursday, September 8th, the evening, and this will be an update on syphilis management and the problem that's occurring in Southside Virginia. There has been an increase in the number of cases, and unfortunately, including multiple cases of congenital syphilis, babies born on mothers with active syphilis. Dr. Barocco is a medical officer for the Virginia Department of Health. She'll be bringing this program to us. And then the third and final September program is on Thursday, September 25th, again in the evening, where we're going to have a women's health update. We have 2 excellent teachers coming to us to help from Carilion. Dr. Heather O'Connor Greer, as you can see, will talk about an update on diagnosis and menopause management, and then Dr. Sarah Evans on urogynecological disorders, things such as incontinence and other female issues of that nature. All that being said, it's my privilege and pleasure to introduce you to Dr. Alexander Reddy, who's the director of the Duke Raleigh Motility Laboratory, part of the Duke GI division, if you will. Dr. Reddy is originally from Alabama, but he began his educational journey at the University of Pennsylvania in Philadelphia, where he graduated magna cum laude with a bachelor's degree in biology. He also was a member of the varsity soccer team there. This was followed by him returning to Birmingham, Alabama for his MD degree at UAB, as it's known, where he graduated cum laude and was selected for the Medical Honor Academic Society, the Alpha Omega Alpha AOA Society, which is a really distinct honor. He came to Duke following his MD degree for his internal medicine residencies and then his GI fellowship there. He has numerous publications, and he is a often invited peer reviewer for numerous high-impact GI journals. He is a delight with whom to talk. We are so pleased to have him this evening do the program. And so, Dr. Reddy, if you want to bring up your slides, mine will pop off, and we thank you so very, very much.
Thank you so much, Dr. Moore, for that really kind introduction. I'm very excited to be here tonight. Give me a moment while I share my slides here. Let me see. One moment, actually.
We see the slides if you just go to presenter view.
Yes, one moment.
They're gone now, yeah.
And hopefully they are appearing now. Is everyone able to see them?
Yeah, looks good.
Okay,
Super
excellent.
duper.
All right, well, we'll go ahead and get started then. Again, thank you for the kind introduction. Today we will be speaking about an update on esophageal disorders. with some of the content relevant to my clinical practice, as I am a gastroenterologist with Duke Health, but have a special focus in esophageal disorder management. So we'll be talking about some of the topics that I think are important, but as well, we'll also be reviewing some additional topics that you all identified as other learning points that would be valuable. Just to revisit the learning objectives once again, during this program, we will be talking about, and hopefully at the end you'll have improved competency to diagnose and to manage gastroesophageal reflux disease, or GERD, eosinophilic esophagitis, which I will at times then refer to as EOE, and esophageal motility disorders, including presbyesophagus and achalasia. In terms of the order of events for this evening, we'll start with GERD, and while we'll be talking about both diagnosis and management, we'll spend additional time focusing on management, and therein reviewing the role of proton pump inhibitors, or PPIs, and then discussing possible adverse effects and drug-drug interactions, which are commonly talked about, represented in both medical as well as in everyday media, and something that becomes a very frequent conversation point in my clinic, and I'm sure in a lot of yours as well. We'll then move on to speak about eosinophilic esophagitis, or EOE, having special focus on symptom recognition, then reviewing the difference and the different strategies between medical and dietary approaches in the management of EOE, and then finally reviewing the critical importance of long-term adherence to a treatment plan in this condition. And then finally, we will speak about esophageal motility disorders, and specifically focusing on presbyesophagus dysphagia and achalasia, talking about the recognition and management of both, and as it relates to achalasia, specifically describing the roles of dilation versus surgical myotomy and the management of this condition. And so we will start with a case. And I want you to imagine that in your clinic, you're seeing a 48-year-old female who has obesity, hypertension, and depression, and they're coming in for their annual wellness visit. During the visit, they bring up that they've been having severe heartburn and regurgitation symptoms over the past year that are getting worse over the past several weeks to months. They've been using some over-the-counter antacids, but haven't really found those to be particularly helpful. And they've heard that omeprazole works well, but they've got several concerns about side effects, including whether or not they might develop osteoporosis or dementia if they use these types of medications. And so with this patient in mind, I want you to be thinking about a few things, asking yourself, what would you do next? Do you think that this patient needs an endoscopy? Is this patient right to be worried about the side effects of omeprazole or other PPIs? And are you worried about the side effects and possible drug interactions? And would your concerns change if this was a patient who had recently had a coronary stent placed, or somebody who has a seizure disorder, or somebody who has HIV? So I want you to be considering all these different facets as we talk through the case and we talk through GERD. And to start with, I want you to consider, what is gastroesophageal reflux disease? I think we all probably frequently hear about this, see patients with it, and manage it often. However, what is the exact definition of GERD? We know the symptoms of heartburn or acid regurgitation, but how is it strictly defined? And this has been described in the literature in various forms over time with an evolving definition. However, the probably first well-established definition came out in 2006, in which they said that GERD is a condition that develops when the reflux of stomach contents causes troublesome symptoms and/or complications. And I think most people would agree that yes, this sounds like GERD. However, it's worth noting that the symptoms of GERD, heartburn, regurgitation, these don't necessarily equate to GERD. And over time, we've come to acknowledge that these symptoms could represent other conditions, including conditions that we'll also speak about later in the talk, cardiac conditions, also orthopedic or costochondritis type conditions. And so the definition has been evolved over time, with an even more substantial update in 2018 with what was called the Lyon Consensus, in which thought leaders in the field concluded that clinical history, questionnaires, and response to anti-secretory therapy, like PPIs, those are insufficient or not enough to make a conclusive diagnosis of GERD. But these symptoms are of value in determining if further investigation might be needed. And so then, just last year, the Lyon Consensus was updated once again to provide very firm, clear, and objective definitions for what GERD is. And now, in order to be formally diagnosed with GERD, you do need to meet one of these very specific criteria. On endoscopy, you need to have evidence of erosive esophagitis, which is described with something called the Los Angeles Grading Scale, with levels of B, C, and D representing essentially mild, moderate, or severe erosions related to reflux disease. Other ways that reflux disease is formally diagnosed is if you have biopsy proven Barrett's esophagus, if you have a reflux-associated peptic stricture, or if you undergo formal ambulatory reflux testing, in which we quantify how much acid is reaching the lower esophagus. And on that testing, if you have an acid exposure time greater than 6%, then you do formally have GERD. The point of going through all this is that there are very specific and clear definitions of GERD, and to remember that heartburn and regurgitation don't necessarily equal GERD. And so what will you do when somebody faces you in the clinic complaining of heartburn and regurgitation? Having some initial steps in therapy is still appropriate, even if you're presumptively managing GERD. And some of the initial approaches focus on non-pharmacologic strategies. I imagine that we're all largely familiar with some of these approaches, and they include avoiding foods that are often triggers for these symptoms, with people often saying things like tomato-based products or chocolate are particularly bothersome. Other people might say that caffeine or carbonated beverages can be troublesome as well. And there is, in fact, some evidence to support that high doses of caffeine can cause lower esophageal sphincter muscle relaxation and actually can promote reflux disease. Similarly, we know carbonated beverages can cause gaseous expansion of the stomach, which in turn can also promote reflux disease. So some of these approaches are actually very valid and supported by evidence. Other pharmacologic or non-pharmacologic approaches also include trying to avoid eating before going to bed, or at least trying to remain upright for 2 hours or so after ingesting any food or liquids in order to prevent any sort of gravity-associated reflux symptoms. However, perhaps the most impactful non-pharmacologic approach, and one that maybe isn't always stressed, is weight loss. Of course, this can be easier said than done, but weight loss has many benefits for people who are in an overweight or obese category based on BMI, and treating GERD is also within that realm. We do know that increased central adiposity in the setting of obesity creates increased intra-abdominal pressure, and this pressure, once again, can promote GERD. So studies have shown that even modest weight loss of around 2 to 5% of total body weight can improve reflux symptoms. Of course, some of these things might not be enough, and pharmacologic management might be the next step. Antacids, which can be found commonly over the counter, such as calcium carbonate or aluminum-containing products, do work because they neutralize stomach acid and act as a buffer. However, there is a separate set of antacids that we call alginates, or over-the-counter medicines that do contain an algae or seaweed component. And these have been shown to be particularly effective when managing reflux disease. Not only do these contain a buffer-type solution, which can neutralize stomach acid, but the algae component actually expands upon hitting stomach acid and forms what we call a raft, or a small physical barrier that can prevent contents from the stomach moving back up into the esophagus. These are found on the shelves just like any other antacid, but something that you can encourage patients to read the label specifically and look for compounds that are described as alginates or have algae in them, because they do have a separate added benefit. However, I think we all are somewhat familiar that acid suppression has been for some time and still remains one of the main approaches to managing reflux disease. And these next 3 bullets highlight the different pharmacologic options that are currently available for acid suppression. We'll start with H2 or histamine blockers, which have been around for about 50 years or so, with cimetidine being the first one introduced in the 1970s. And we know that these medications work. In fact, when they first came out, they were felt to be, in some ways, a godsend, a blockbuster medication. In fact, cimetidine was the first medication ever to get that title of blockbuster medication because it was able to gross over $1 million in pharmaceutical sales. And we know that they work well. However, it is worth also noting that they don't work as well long term. All H2 blockers are vulnerable to an effect that we call tachyphylaxis, meaning that the more you use the medication, the less effective it becomes over time. Something just to consider if you are recommending or any of your patients are using these medications. While these medications work well, we do know there's a separate class of medications that has now become ubiquitous, extremely common, extremely easy to get, and also very effective, and that's the proton pump inhibitors. Later in the talk, we'll describe more about not only how these work, but also some of the potential concerns that are raised and whether or not we think that those are truly valid or not. However, some of you might not be aware, and some of you might be, that there is a newer class of acid-suppressing medications. And these medications are called potassium competitive acid blockers, or PCABs for short. These medications have been around for a little over a decade or so and are becoming more and more commonplace in US markets with some new FDA approvals within the past couple of years. These medications are more effective in terms of lowering acid in the stomach compared to PPIs, and their role within the management of GERD is evolving and will likely become larger as time comes on. And finally, there are additional non-pharmacologic or procedural interventions that can occur for anti-reflux purposes. These can be advanced endoscopic approaches or surgeries in which you essentially reinforce the lower esophageal sphincter to prevent reflux from happening. I think that most of the members on the call, though, are not surgeons, and therefore some of the non-pharmacologic and pharmacologic approaches at the top of the slide will be the mainstay of what you might consider. And so let's talk about some of these pharmacologic approaches in a little bit more detail. This isn't meant to be highly specific or get into the weeds, but this is a parietal cell, the cell in the stomach that makes stomach acid. And we already talked about how acid suppression might work with histamine blockers, which block this receptor here and essentially prevent the cascade of different signals that eventually leads to acid being produced. We also know about proton pump inhibitors, which affect the proton pump right there, and essentially at the surface of the cell prevent acid from being released. However, the newer class of medications, the potassium competitive acid blockers, or PCABs, they function right here, also on the proton pump, but at a very specific channel, exactly where the acid is being released. Some of you might be wondering, this sounds very similar, affecting the exact same spot as the other medications. Why were these made? What's sort of the big deal? And while they do seem similar at first, there actually are several key distinctions between these different classes of medications. Just to orient you, as you know, PPIs often end in the PRAZOLE suffix, or prazole, contrasting that with this newer group of medications, the PCABs, that end in a prazan, or PRAZAN. So similar, but a way to distinguish that if you see this ever written, you know what this type of medication is. A lot of us might be familiar that PPIs, in order to be most effective, typically need to be taken about 30 to 60 minutes before meals. And the reason for that is, one, they're not acid stable, and therefore they work better before there's too much acid in the stomach. But secondly, they're what we call prodrugs, meaning that they're not the active form of the drug, and that they actually need to be metabolized by the liver before they can be effective. That means you need a little bit of lead time before the proton pumps are fully engaged in order for it to be metabolized. However, you contrast this with the new type of medication, the PCAB, these concerns aren't there. The PCABs are already in their active form. So that means that you can take them any time of the day that you might want, independent of when you're having meals. Additionally, PPIs, like I said, need to be metabolized by the liver. And this is predominantly done by CYP enzymes, and one in particular, the CYP2C19. And this type of metabolism is the real main reason why PPIs might have different types of drug interactions. However, with PCABs, this concern about drug interactions due to metabolism doesn't happen because they don't need to be metabolized before they can work. Additionally, not only are these PCABs able to be taken at any point in the day because they don't need to be metabolized and because they're acid stable, but they actually work more quickly and effectively. They essentially, I won't say better, but they're stronger than PPIs. And this has been shown with some really clear and helpful research that's been done. So these are some graphs from a randomized control trial in which patients had their stomach acid measured at baseline. And if you look at the day one chart on the left, that's that light gray mark that shows that the pH was low or very acidic at a level of about 1 to 2 in patients who didn't have any type of medication for acid suppression. Compare that to a common PPI like lansoprazole. When the patients took this medication, it did suppress their acid levels. In the stomach, we consider well-suppressed acid levels to reach a pH of 4 or higher. So on the first day of taking lansoprazole, somebody, if you look at this dark blue line in the graph on the left, is probably only getting what we call quote-unquote good acid suppression for probably only a few hours, maybe 2, 3 at most. Compare that with the new medication, the PCAB called vonoprazan. You can see that for probably half the day, patients were receiving what we call good or adequate acid suppression. Then you move to the chart over on the left. And this is after a week of taking the medications. Again, the gray line, the chart on the right. If you look at the gray line, again, if you're not taking any medications, you're going to have a low pH in the stomach. If you take lansoprazole, you're going to have suppressed stomach acid, but your pH is only going to be above 4 for about half the day. However, if you take the newer medication vonoprazan, the pH is going to be above 4 for the entire day. And so yes, we have evidence to show that this newer class of medication is more effective. And because of this effectiveness, there have been ongoing FDA trials and approval for it. And vonoprazan is now currently FDA approved for 2 indications in the United States. This is for H. pylori eradication and the management of erosive esophagitis, which we said earlier is one of the hallmarks or definitive ways that you can diagnose GERD. Vonoprazan is approved for many other indications in other countries, specifically in Japan and other areas of Asia, where the medication has been used for about a decade and has more long-term data and support. So while this medication, as I've shown, does work very well and is approved for several things that we might see commonly, PPIs are still going to be the mainstay of managing GERD and other acid peptic disorders. And we know that there's several different ones approved in the US with names we might all be familiar with: pantoprazole, omeprazole, esomeprazole, lansoprazole, and some other that you might not use as commonly, such as rabeprazole. These are approved not only for GERD, but for GERD complications, like Barrett's esophagus, as well as other things, treating H. pylori, upper GI bleeding, and Zollinger-Ellison syndrome. And so these medications are still really helpful and will still be used commonly, as PPIs are still the most commonly prescribed medication class amongst gastroenterologists, and based on large consensus data, pantoprazole and omeprazole continue to rank in the top 10 most commonly prescribed medications amongst primary care providers. In short, PPIs are still here and likely will be for a while, and I anticipate that we'll continue to use them regularly. And with any medication that might be used regularly, questions arise about, are we doing the right thing? Is it safe? And there have been multiple different types of studies, some of them more observational with lower rigor, and some of them randomized control trials, as well as other media press around the safety of PPIs. And I get questions about it a lot, so I imagine you all might as well. Like I said, there's varying levels of evidence. And if we look at what is the highest quality evidence, which would be randomized controlled trials that have a placebo-controlled arm, really what we've seen over time is that there actually aren't many proven side effects. There's been one hallmark study that looked at just over 17,000 patients who were randomized to receive PPIs or not. And patients were followed out for a duration of 10 years. And what this one study showed is that there is a well-established side effect of enteric infections, and more specifically, Clostridium difficile, or C. diff. And the study was powered to see that there was a difference. However, the rates of these infections were still overall low. People who were on PPIs got C. diff and other enteric infections 1.4% of the time, compared to 1% of the time within the placebo group. So 0.4% was not a huge difference, but it was statistically significant. To contrast that, there were no other clear associations with any other bad outcomes in this study. So things including chronic kidney disease, dementia, pneumonia, COPD, cardiovascular disease, and all-cause mortality, none of these were linked with PPI use in the study. So when I counsel patients, I certainly tell them about the enteric infection risk, but that it's overall low, and that the highest quality evidence that followed patients for a duration of 10 years did not observe any of these other side effects. If asked about what would be mechanistically possible, but again, not good evidence of, I think that there probably could still be an argument to say that there might be vitamin and mineral deficiencies associated with using PPIs long term, and that in turn, this could theoretically lead to some decreased bone mineralization. Again, the evidence didn't necessarily bear this out, but I think with lower acid levels, you could imagine a situation in which absorption of certain vitamins and minerals and those required for bone mineralization might occur. This doesn't necessarily change recommendations in terms of if we should be screening patients with DEXA scans earlier or checking vitamin or mineral deficiencies regularly, but something that I think could still be possible. However, again, based on the evidence, really, there's nothing to support saying that there's increased risk of pneumonia, CKD, cardiovascular disease, dementia, or all-cause mortality, and I do share that with my patients. The next topic I'd like to engage in, though, is a discussion around drug-drug interactions with PPIs, because these are potentially common and things that you might have heard about or even think about regularly. Perhaps the most famous one is with regards to omeprazole and clopidogrel. As I said before, omeprazole and other PPIs, they are prodrugs, so they need to be metabolized by the liver in order to be effective. Clopidogrel is in the exact same situation. It's a prodrug. It also needs to be metabolized to have its antiplatelet effect. So
Dr.
the
Reddy?
concern, yes,
We have a question in the chat. So
absolutely.
I'm going to read that to you. So good evening, everyone. This is from Dr. McIntosh. Dr. Alexander, when would you consider invasive H. pylori testing for such presenting symptoms in this patient well below 60 years? Thank you.
I want to make sure I understood the correction,
Okay.
the question. A question around invasive H. pylori testing.
Pylori testing for such presenting symptoms in this patient. So perhaps referring to the previous patient well below 60 years.
Absolutely. That's a great question. I would say that in a patient below 60, and I mean, honestly, at just about any age, I would strongly consider H. pylori testing. And the presenting patient had heartburn and regurgitation, epigastric pain, nausea. These could all be theoretical symptoms of H. pylori. With regards to the question around invasive testing, I would say that when I hear that term, I think about endoscopy and biopsying for H. pylori. However, the data would actually support that what I might describe as non-invasive testing, which can be done with a stool antigen test, or in some areas by doing a urea breath test, actually have better test characteristics. So those two tests, the stool antigen and the urea breath test, have higher sensitivity and specificity, about 95% sensitivity and specificity for both of them. Those can be affected if patients are taking PPIs. So in this patient example, if they came with these symptoms and had not yet started any acid suppression, I think one of the first things that I would do would be to actually test them for H. pylori. Again, can be relatively easily done. And I would make sure that they do it while they aren't on any acid suppression to make sure that the test is as accurate as possible.
Okay, thank you.
I will jump back in and sort of say that I was just briefly talking about omeprazole and clopidogrel, and the fact that if omeprazole is getting metabolized by the liver, that might prevent clopidogrel from getting metabolized or lead to what we might call inhibition. And therefore, clopidogrel might not be as effective. And we know that this is an important antiplatelet medication for people who might have coronary disease. And so this has also been studied in a prospective randomized control trial. And in this situation, patients were on clopidogrel and they were randomized to have omeprazole or a placebo, and they were followed out over the course of 6 months to see if they developed any cardiovascular events. And I think the reassuring news is that there were no increased events with regard to cardiovascular disease after 6 months, but there was an increased risk of GI bleeding. And this was demonstrated here in some tables from that study, with the table on the left showing the risk of cardiovascular events, with those patients taking omeprazole in red and those in placebo in the blue. And you can see that the lines are essentially the same, meaning that there was no increased risk. But in the table on the right, you can see that there was a little bit difference in terms of bleeding. So the red line is a little bit higher, indicating that there was less bleeding when on omeprazole, compared to a little bit more upper GI bleeding when patients were on placebo. Taking this data in mind, I would say that omeprazole and clopidogrel together, they're probably safe and probably okay to take. However, there is some potentially easy workarounds. You can use an alternative PPI, and specifically pantoprazole, because we know that this medication actually is metabolized less and leads to less CYP inhibition in the liver. Alternatively, you could use a different form of acid suppression, like an histamine blocker, or even the new class of medication, PCABs, because we know that these don't get metabolized by the liver in the same way.
Dr. Reddy?
Yes.
Me again. Dr. Pandya has a comment. He said your comments on NERD.
My comments on NERD as in non-erosive reflux disease.
Do you have a microphone, Dr. Pandya? Do you want to elaborate on that?
Yes, in your definition for GERD, you had mentioned about evidence of consequences of acid damage, either with erosions or stricture or Barrett's. In practical terms, in non-erosive reflux disease, you may not have any mucosal damage apparent. Do you consider that as a treatment for chronic reflux as well?
That's a great question, because you're right. Those findings on endoscopy are not always there for patients who have GERD, and they would fall into this category of NERD, or non-erosive reflux disease. Empiric management, as we sort of talked about, is certainly reasonable. And in a couple minutes, I'll also comment on this as well. But I would say that if somebody isn't responding to some of your initial empiric therapies for reflux disease, and even if they don't have these changes on endoscopy, in that situation, in order to diagnose non-erosive reflux disease, we would recommend formal ambulatory reflux testing, which can be done through two different varieties, either a pH test with an intranasal catheter or a wireless pH catheter or probe. And essentially, we would then directly measure acid levels in the lower esophagus to try and make that diagnosis of non-erosive reflux disease. So the management can be similar up front, but if there are questions about whether non-erosive reflux disease is present, then doing that type of formal acid testing is my recommendation.
Dr. Reddy, just to follow up, access to those pH monitoring has been extremely difficult. How accessible, other than in your own lab, do you see in the community practice for pH monitoring?
That can be a challenge, and I do agree that it is more commonplace in larger centers that have increased capacity. I will say, though, that there are a number of smaller health systems and even private practices that do offer this type of testing. And the testing also doesn't have very long wait times at our center, I will say. So if referrals were placed to our center, specifically, or especially if it was to be an intranasal catheter test, those are often completed in the course of, once the referral is received, several weeks. And so while the centers might not be all that local, hopefully wait times wouldn't be that long if this type of testing was needed. And the importance of this testing is really to make sure that you are heading down the right track with these various options for GERD management. And it would be unfortunate for a patient to have an alternative diagnosis and continue to receive acid suppression as opposed to getting directed to the right type of care earlier. And so that's part of the emphasis for this type of formal reflux testing.
If I can have one more question, in what situations do you put your patients on long-term PPIs?
So I utilize long-term PPIs in a couple of scenarios. One is if somebody clinically is presenting with symptoms of reflux disease and they have a good response to proton pump inhibitor therapy, then what I'll generally recommend is that they use it for several months and then try to wean off. If patients have recurrent symptoms after weaning, but then when they go back on, their symptoms are gone, I think that is a reasonable time to consider PPIs long-term. And so that would be, again, largely just symptom-based, but I think a very reasonable time to use PPIs long-term. The goal is always to use the lowest effective dose for the shortest period of time, and that's why I will, over time, for these types of patients, recommend trialing off. However, there are some people who really don't feel well when they trial off, and so to continue is reasonable. Other situations in which I would continue it long-term, if somebody has a diagnosis of Barrett's esophagus, or has any of the other endoscopic findings that I'd seen before, I would be worried about those findings getting worse. And therefore, I would probably recommend using this therapy long term. The other situation outside of reflux-related conditions, at least as it relates to the esophagus, would be management of eosinophilic esophagitis, which we can touch on in just a couple of minutes.
Thank you.
Of course. And so just to briefly conclude with some of the PPI discussion, just so that you're aware, there are some other drug interactions and that in a very similar way to clopidogrel, there can be other effects. And so we do know that there are increased concentrations of SSRIs when taking PPIs, specifically citalopram, and sertraline. There can also, although not as well proven, be potential increased effects of warfarin as well as anti-epileptic medications, specifically diazepam, phenytoin, and carbamazepine. Additionally, there are some interactions that are not related to liver metabolism, but just the fact that an acidic environment is often needed for some medications. These include some commonplace medications like oral iron supplementation and levothyroxine. And just to touch on levothyroxine briefly, this is a medication that is, shall I say, a little bit finicky or needs just the right conditions to be absorbed. So it's often recommended not to have it with food or other medications. And it's also noted that it does need an acidic environment in order for it to be properly absorbed. And so taking a PPI could inhibit the way that levothyroxine is absorbed. There have been some studies to say it doesn't matter if you take your once daily PPI in the morning or at night, and it doesn't. Ultimately, any dose of PPI likely could affect this. And so in these situations, I don't necessarily say that patients can't be on PPIs, but that they need to be consistent and that doses, especially levothyroxine, can be adjusted, thankfully, to accommodate for some of these issues that might come up with PPI use. To kind of contrast that, antifungals and more specifically antiretrovirals, these might have a little bit higher stakes, and therefore making sure that they are absorbed well is crucial, especially because they often don't have variable doses. And so in these situations, this is the type of environment where I would say maybe you don't want to be taking a PPI, and you can use an alternative, like we mentioned, H2 blockers. And in fact, using an alternative is helpful for all these situations, of course. But another possible solution is using pantoprazole. Again, it is a medication that doesn't affect the liver metabolism as much, but we actually know it also doesn't lower stomach acid as much. We all might have been taught or think about PPIs as being essentially all the same, but in fact, we know that they're not. And there was a somewhat landmark study done several years ago now in 2018 that sort of assessed the strength of different PPIs. And it looked at omeprazole, since that was the first PPI ever made, and basically compared the strength of omeprazole and called it omeprazole equivalence for all of the other medications. And so in the chart here, you can see that pantoprazole 20 milligrams is the same as 4.5 milligrams of omeprazole. Or said another way, pantoprazole is about 4 times weaker than omeprazole. To contrast that, rabeprazole is another PPI, and 20 milligrams of rabeprazole is about 36 milligrams of omeprazole. Or said another way, rabeprazole is about twice as strong as omeprazole. So just to keep in mind that not all PPIs are the same, and that making some changes like using a weaker one, such as pantoprazole, can be helpful for drug-drug interactions, or using a more effective one like rabeprazole might control symptoms better. We briefly sort of touched on what to do when PPIs aren't improving symptoms. One of the important things is to make sure they're taking it and that they're taking it properly, 30 to 60 minutes before meals, so that it can be activated in the right way. You should always be thinking about alternative diagnoses and can't miss diagnoses, including cardiac evaluation, as we know that some patients, classically elderly women, might present with atypical chest pain symptoms of coronary artery disease. And then finally, a referral to GI for the endoscopy and the ambulatory reflux testing, as we discussed, can be really valuable to make sure that we have an accurate diagnosis and that we're deploying all the right treatments. However, you can also refer directly to endoscopy, and there are some additional considerations in which I'd encourage you to do this. If there are any alarm symptoms, like patients are also not only having heartburn and regurgitation, but also having trouble swallowing, they're having odynophagia or pain with swallowing, or unintentional weight loss. And then finally, you can also consider about whether you should be screening for one of the known complications of reflux disease, Barrett's esophagus, which does increase the risk of esophageal cancer. The guidelines do recommend deploying some form of screening. However, the guidelines also admit or recognize that we probably have a large collection of patients who have Barrett's esophagus who we are still missing with this screening approach. However, these are still the national recommendations that if patients have multiple of these risk factors, being male, over 50, having long-term symptoms, obesity, tobacco use, or if they're white, having 3 or more of these should trigger someone to consider screening for Barrett's esophagus. All right, we'll now move on to case number 2. You're seeing a 35-year-old male who has asthma and allergic rhinitis, and they're coming in the clinic after recently being in the emergency department. They were there 2 weeks ago after they had a choking episode on a piece of steak. While in the emergency department, their symptoms resolved, and the patient was started on a proton pump inhibitor before being discharged home. When you see him in clinic, he says that he hasn't had any other issues with swallowing since that time, but on further questioning, he does say that over the past year, he's been eating a little more slowly, finds that he requires extra sips of water to swallow, and that oftentimes he's sort of coughing or trying to clear his throat a lot after meals. For this patient, I encourage you to think about what is the most likely diagnosis, and what would you do next? Do you think that this patient needs an endoscopy? Was starting a PPI a good idea for this patient? And when you screen for dysphagia in the clinic, do you simply ask, are you having any trouble swallowing? Or do you think about changing your approach and your questions based on the details of the patient in front of you? And so this is a patient example of somebody who most likely has a condition called eosinophilic esophagitis. And this next slide is not meant to go into any detail or to scare you, but just to highlight that this is a complex disorder that we've learned a lot about, but probably still have more to learn as well. It's an allergic type reaction in which some sort of allergen exposure, most likely food, but potentially something in the air, leads to a long inflammatory cascade that ultimately results in eosinophils and other inflammatory cells activating in the lining of the esophagus and causing bad inflammation, and then potentially stenotic changes like strictures. And the hallmark presentation is a young person, often male, but not always, who's coming in with new onset trouble swallowing. We used to think, though, that this was just a condition of young people, including pediatric patients, but we're now discovering that this is actually much more commonplace than we ever thought. And I've diagnosed people who are in their 80s with this condition. And so just to say that this really could happen in just about anybody. And in that way, they might present with different types of symptoms. They might not clearly say that they choked on a piece of steak, but might have more subtle findings or things in the EOE literature that have been described as impact behaviors, an acronym to highlight some of the subtle changes that could happen, especially if you have a otherwise young and healthy person in front of you, and things that you might want to wonder or inquire about to recognize these subtle symptoms. So are they imbibing fluids or drinking a little bit more when they're eating? Have they modified their meals by, say, cutting things into small bites? Are they prolonging their meals? Are they taking much longer to eat? And are they the slowest person at the table all of a sudden? Do they avoid hard texture foods like meat or crusty breads? Do they find that they're chewing excessively? And do they turn away tablets and pills? Not only are they having to sort of turn their neck or turn away while they swallow, are they now just refusing to take these types of things or avoiding them because they say they don't like them? These could all be some subtle signs of eosinophilic esophagitis. In order to diagnose the condition, there are 3 hallmark criteria that do need to be met. They need to have symptoms of esophageal dysfunction, which can fall into a lot of different categories, but mainly dysphagia, heartburn, could include regurgitation, or non-cardiac chest pain, a lot of the same symptoms that we talk about with GERD. However, they also need to have histology findings or biopsies of the esophagus that show more than 15 eosinophils per high-powered field. And you need to exclude any other reason why they'd have eosinophils in the esophagus, meaning that they don't have some hypereosinophilic condition, they don't have any type of infection, specifically parasitic, and they're not taking any medications that could lead to this as well. Whenever somebody is diagnosed with EOE, there are essentially 2 large algorithms or 2 buckets in which patients might choose to manage the disorder. They could choose pharmacotherapy with medications, or they could choose dietary approaches. In terms of medications, there are a few options, and one of the most commonly used medications, even though it is an off-label indication, is PPIs. We already reviewed how PPIs lower stomach acid, and that probably has some effect here, and that lower stomach acid might protect the esophageal barrier better. However, the real benefit from PPIs is actually an anti-inflammatory effect. We know that these medications downregulate a marker that's called eotaxin 3, but essentially downregulating this helps prevent eosinophils from reaching the esophagus, and so they have an anti-inflammatory approach. You can also use steroids like fluticasone or budesonide specifically. Systemic steroids would probably be helpful, but these 2 types of steroids actually act locally, or we call them topical or non-absorbed. This means that these medications should not cause some of the other side effects associated with something like prednisone or other systemic steroids. So we don't think that these medications would lead to adrenal insufficiency or osteoporosis, but we do think they act locally in the esophagus to decrease inflammation. And then finally, there is a biologic medication that was just approved a few years ago and is being used more and more commonly called dupilumab. It's a IL-4 receptor inhibitor, so it downregulates IL-4 and IL-13, but all to say it interrupts the inflammatory response to help treat not only EOE but other atopic conditions as well, including asthma, eczema, and nasal polyposis syndromes. So there's a lot of good options to use here, but on the flip side, there's also dietary approaches, which focus on essentially avoiding the key triggers that might have caused all of this in the first place. EOE is a type 2 inflammatory reaction, so it's a bit different than, say, anaphylactic reactions or type 1 reactions. And therefore, skin pinprick testing or other testing really isn't helpful in identifying the specific food that's the problem. And in fact, patients probably aren't necessarily having symptoms when they eat the specific food that's causing the inflammation, but yet it's part of this whole triggering cascade. These food categories, they're broad. They include dairy, wheat, eggs, soy, peanuts and tree nuts, and fish and shellfish. And when you're going through a dietary approach, you choose to eliminate one of these major categories, multiple of them, or potentially all of them. And the EOE guidelines do sort of highlight which ones of these you might be using. If you're going to eliminate one, dairy would be the choice. But then if you're going to eliminate multiple, it then would be wheat, egg, soy, eventually nuts, and then seafood in the order I listed. So those are the orders in which it's most common that these are the triggers. There's also one other dietary approach that we call an elemental formula, which is an amino acid-based hypoallergenic formula, typically reserved for children, but could theoretically be used in adults. It's essentially a special tube feeding that avoids having to intake any of these other products. Now, there are different effectiveness of all these different approaches, and I've sort of highlighted these here in this chart. The dietary elimination or food elimination diets, FED, are highlighted in blue, and then some of the other medications in other colors. When I talk with patients about what they want to do, these are some of the information that I provided them. That a single food elimination, eliminating dairy, works about 40% of the time. If you do a 2-food elimination of dairy and wheat, about 45. If you eliminate dairy, wheat, soy, and eggs, probably looking at about 50% chance of response, which is the same as PPIs. If you use topical steroids, that goes up to about 65%. If you eliminate all the food groups, 70%. If you do this tube feeding, probably 90% chance of success. However, this biologic medication in the study that got it FDA approved for EOE, it had a complex crossover design, but in patients who took it for up to a year, they found that all of them actually reached histologic remission or had a good response. Essentially saying that we think that almost every patient who is on dupilumab long enough probably will have a good effect. And it's not only important to get them on the medication initially, but to have them be on it long term. Because we don't know, but we do suspect that patients with EOE, if they go on without treatment, they're probably going to develop fibrostenotic disease, or they're going to have a stricture. And we know it's not enough just to get a patient under control once, but that we have to keep them under control. Because if you stop these therapies, within a year, almost every patient is going to have recurrence of their symptoms. And that's why maintenance is really the most important thing. It's very, very strongly encouraged because EOE is a chronic long-term disease. We have ways to manage it, and good ways, as you saw, but we don't have a cure. And so sometimes it's really important to reinforce that this is something that will probably be with them for their whole life. And then finally, we'll end with patient case number 3. I want you to think about an 82-year-old female who has COPD, osteoporosis, and is coming in after a recent admission with shortness of breath. During the hospitalization, they were concerned that the shortness of breath was from aspiration pneumonia, and a barium swallow was performed during the admission that demonstrated, quote, moderate esophageal dysmotility. You're now seeing them in clinic for post-hospital follow-up, and they say that they do sometimes have trouble swallowing, specifically when they're not chewing food appropriately or they're forgetting to wear dentures. So I want you to think about this patient and wonder what might be going on and how much of their symptoms do you think are due to oral issues of not chewing or not wearing dentures? Do you think that this patient needs an endoscopy? And how do you think about or manage esophageal dysmotility? Here is a picture of the barium swallow from the inpatient stay. I want you to think about, is this concerning? What do you think is the diagnosis here? And do you think that any additional evaluation might be warranted? This here is a picture of a barium swallow with something we might call presbyesophagus, which is a radiographic term, meaning it's a description just seen on X-rays of age-related changes in the esophagus. We do know that sometimes these age-related changes can lead to some trouble swallowing because there's impaired reflex arcs, which is a key part of how swallowing happens. And there's also reduced sensitivity, meaning that these reflexes aren't triggered in the normal way because patients aren't sensing that food is in the esophagus normally. It's commonly associated with dementia, diabetes, and reflux disease. However, I want to highlight that again, that this is a radiographic term and that it is a non-specific motility disorder. As time has gone on, we've had, just like GERD, more specific criteria for diagnosing esophageal motility disorders, and they're now defined using something called the Chicago classification based on manometry. And so while this isn't a formal diagnosis, it can still be a clinically relevant one. And so helping to manage some of the comorbidities like dementia and diabetes are key, but since it's associated with GERD, empiric acid suppression could also be considered, as well as perhaps more importantly, behavioral modifications. This includes if patients are eating, but they chew well, and that if they wear dentures, they have them in when having meals. They use additional liquids when eating solid foods to help promote movement of these solid foods through the esophagus, and that they stay upright, usually for at least an hour or two after eating or drinking anything in order to use the benefits of gravity to help things pass through the esophagus. I want to again highlight that radiographic studies can be helpful, and that there's a variety of different things that you might see with regards to esophageal motility disorders. But again, that these are radiographic descriptions and not necessarily diagnoses. You see this example again of presbyesophagus on the left with a little bit of tortuosity, maybe a little bit of dilation. But you compare that with what might be described as corkscrew esophagus in the middle, with something that almost looks like a wine bottle opener and could represent esophageal spasm. Or the example on the right, where you see what's described as bird's beaking, where there's a very tight narrowing at the lower part of the esophagus with even more impressive dilation upstream, and that this might represent something like achalasia. But I think it's important to remember that these are all, in modern day, just something that we say might be the case, and they need to be confirmed. And the way to now confirm and formally diagnose an esophageal motility disorder is with esophageal manometry. This is a test in which a catheter, essentially a nasogastric tube with a bunch of pressure sensors on it, is placed in through the nose, down the throat, down the esophagus, and into the stomach. And then through a sequence of different swallowing exercises, while patients take small sips of an electrolyte-containing Gatorade or other type of electrolyte-containing solution, they then have their recordings done to measure the muscles of the esophagus with readouts that look like this. This is a large portion of my job, is interpreting these studies and then using what's a complex diagnostic schema to figure out whether or not motility disorders are present. Of course, the most important and the one that perhaps is most actionable is over on the left-hand side in orange, which includes the group of achalasia or achalasia spectrum disorders. And one of the hallmark features of achalasia is that the lower esophageal sphincter is hypertensive, or it's too tight and doesn't relax properly. And therefore, the mainstay of our therapies is to try and lead to relaxation of the lower esophageal sphincter. So all of our interventions are aimed at the lower esophageal sphincter, or LES. Some people have studied and tried to use medications, but we ultimately have found that they're not very effective. And so the four options that really exist include botulinum toxin injection, pneumatic dilation, or PD, a special type of endoscopic dilation, a surgical Heller myotomy with fundoplication, which is an anti-reflux wrap, or a per-oral endoscopic myotomy, also abbreviated POEM. The last three are underlined because we think about them as our most effective, durable, and long-lasting treatments. And here are some of the details that patients can expect if they were to undergo any of these treatments for achalasia. Botulinum toxin injection is done during endoscopy and is relatively quick. However, it is not a permanent fix. On average, patients only really get effect for about 6 months, with the most that we expect being a year. Unfortunately, this could also complicate any future interventions like the ones listed below it, and therefore we usually only recommend doing botulinum toxin injection once unless patients aren't candidates for other therapies. Pneumatic dilation, again, is a special dilation during endoscopy that is also relatively quick and less invasive. However, it does carry a pretty high risk of perforation, meaning that patients who undergo this therapy really should also be surgical candidates in case any serious adverse effect like perforation occurs. The perhaps one downside of pneumatic dilation apart from perforation is that it also doesn't last as long. It usually lasts about 2 years, but could last up to 5, and most patients require multiple treatment cycles. Contrasting this with something like a surgical myotomy. This is performed by a specialized surgeon who's trained to do this, but is minimally invasive and usually only takes about an hour and a half. The good news about this surgery is that it's probably our best proven one, or at least that has the most long-term data, And we know that patients can have 10 years or even sometimes longer in terms of having good outcomes of symptom relief. It also has an anti-reflux portion to it, which can be helpful. Contrasting that to the newest therapy that's available, the peroral endoscopic myotomy, or an endoscopic myotomy or cutting of the muscles of the LES. This is done, like it says, with endoscopy, takes about just as long as the surgical approach, and can have similar outcomes lasting for about 5 years. The downside to this therapy, though, is that there's no anti-reflux portion. So these patients, about half of them, will go on to develop significant reflux disease. And so when we think about these therapies, which ones do you pick? Of course, it depends on the patient, their preferences, and some of these risks, but it also depends a little bit on the type of achalasia, because there are actually 3 different types. And the type can determine what type of treatment is best, but also how likely it is to be effective. And so just to give you some sense, for some of these therapies, they're equivalent for the first 2 types of achalasia, but type 1's a little bit worse. So anywhere from 2/3 to 90% of people might have a good response, but type 2 is a more favorable form in which the vast majority, 90 or even 100% of people, will have a good outcome. Type 3 is a special type in which we now reserve only this newer endoscopic myotomy approach, but also does have good outcomes. And you can see that with these therapies, even for all of them, all the types of achalasia, about 90% of people might have positive results. And that's great. However, we still need to manage these patients long-term as well. And so at least once a year, symptom assessment and nutrition assessment is still key. One of the ways that is easy and validated to assess symptoms is using something that's called the Eckhart score, something that you all, if you happen to see a patient with achalasia, could easily deploy in your clinic, where you ask them this set of essentially 4 symptom-based questions with a scoring scale from 0 to 3 for each question. So scale of 0 to 12. And scores of 3 or less are generally felt to be very positive results and indicate that patients are having minimal to no symptoms. In addition, like we mentioned, the endoscopic myotomy does have a high risk for reflux disease, so acid suppression is important for these patients. And then, what about surveillance endoscopy? Do these patients need to have endoscopies every so often? Would you know if you have achalasia, you have an increased risk of squamous cell carcinoma, but you also probably have an increased risk of adenocarcinoma of the esophagus as well. However, the guidelines don't recommend doing routine endoscopies because unfortunately, there's been no improvement in mortality with this type of screening approach. All the same, I think that most experts, and myself and my practice included, if patients have been diagnosed with achalasia for a long period of time, 10 years or longer, I will encourage them to undergo this surveillance because I do still think that there is importance in having the diagnostic information and in order to provide some counseling in the event that somebody does develop cancer of the esophagus. So in summary, we've reviewed several different conditions today that are becoming more and more common. Reflux disease and delved into the management, but specifically with PPIs regarding adverse effects and drug interactions. Eosinophilic esophagitis, talking about subtle symptoms, how medications and dietary approaches are both valid and useful. However, long-term importance is the key, and that esophageal motility disorders can come in different forms based on radiographic studies, but now more commonly based on esophageal manometry, and that achalasia is a well-defined condition that we have some good treatments for, but long-term follow-up is still needed as well. And so with that, I will say thank you very much for your attention. Here are some of my references, and I'd be happy to answer any other questions.
Hi, Bennett Fine here. I would like to ask a couple of questions, if possible. When you do esophageal manometry and you have normal Chicago classification, sometimes there are non-specific findings like upper esophageal sphincter, increased pressures, and things that don't fit the classification. I mean, what do you do with those?
That's a great question. I think that it will depend a little bit on the specific finding. but there can be things that are outside of the diagnostic schema. In those situations, it really delve into what symptoms the patient is actually having. By and large, these smaller findings are unlikely to be clinically significant, but I think that asking some more detailed questions to make sure can be helpful. To answer you sort of mentioning the upper esophageal sphincter, if this is a patient who is having trouble swallowing or having recurrent aspiration, then in this type of scenario, maybe I will put a little more stock into that finding and discuss some therapies that we could try to help address that abnormality, even though we don't generally consider that to be a major finding on manometry. So it does depend on their symptoms.
And the
Dr. Pradhan?
only other question is, I would prefer to do Bravo on patients rather than the catheter-based testing, because when I talk to the patients about it, very few of them would want to do the catheter-based testing. And you also get a longer duration of monitoring with the Bravo. So how difficult is it to get a Bravo done at Duke, or, well, in general, I find it a little difficult to get done.
I agree with everything that you said there. Bravo is the Medtronic brand name for the wireless pH monitor. And in general, I would say that that is likely a better test. This is a test that is most commonly placed during an endoscopy, the probe, but it can technically be placed in an unsedated patient without the use of endoscopy as well. It does give you longer information, and probably therefore is more valuable. I'll just make a quick comment that the catheter-based testing can be helpful if you already know someone has reflux disease and you're trying to assess their response to PPI therapy. It is valid to do that type of testing on PPIs as opposed to the wireless, which we customarily don't do on acid suppression therapy.
Right.
In terms of wait times, it can be long at Duke. I will be honest. How long? Probably on the order of 3 months. Sometimes a little bit longer, closer to 6 months, depending on our schedule availability.
Okay, thank you.
Dr.
Reddy?
Pradhan, did you want to
Yes,
ask a question?
Yes, Dr. Reddy, good evening. Thank you for the talk. Couple of things. One, can you comment on PPI resistance? Is it real? Second thing is on-demand PPI to prevent long-term use. Do you do that or not? And third question is approach to patient with GERD symptoms on GLP or GIP products. Thank you.
Just to slightly clarify, PPI resistance as in not getting the same effect long-term, as opposed to not talking about H. pylori.
Right, right.
Okay. There have been studies looking into this, and ultimately we do not believe that there is resistance or that there is decreased responsiveness to PPIs long-term. Theoretically, there is a continued upregulation of the proton pumps over time as you use these medications, and you could theoretically sort of have too many pumps for the medication to work, but that over long-term studies that do look a couple decades, we do not believe that's the case. We do think that histamine blockers, H2 blockers, probably are more prone for this resistance, if you will. Can you remind me again of your second and third questions?
On-demand PPI, i.e., say patient taking long-term to prevent the long-term uses. So sometimes I tell the patient, like before going for the meal, which is contributing to the symptoms of heartburn, acid reflux, I tell them to take the meds like half an hour to 45 minutes ahead. Is it worth it, or is it real? You need at least 2 weeks period to affect all the PPI receptors. So what is your take on that?
My take is that you might get some benefit from doing this, and that if they are going to do it, as you mentioned, taking it 30 minutes to an hour before the meals is key. Otherwise, you might be getting essentially no effect. However, you are only going to be able to reach a small bit of the medication's effect within the first day. And so if they really are hoping to get the most benefit out of the medication, it would be the best approach to take it for at least a week. That's, enough time on daily dosing to get up into the most effective range. For patients in this scenario, I will talk with them about the frequency of their symptoms. And if they're not that frequent, I will often sometimes consider using H2 blockers in this exact scenario, or even the antacids with alginates in them, because they work quickly. In patients who have more severe symptoms, what I'll do is typically, who I think need a PPI, we'll do typically month to 2 month long trials where their symptoms are worse, and we will take it for a month or two, and then we'll discontinue, hopefully for as long as possible, but usually another couple of months. And then if they have severe symptoms, once again, sort of cycle back and forth in that way to try to avoid using the medication, not too much, but trying to use the lowest effective dose possible.
Perfect. Last question is approach to patient with GERD symptoms on GLP or GIP product.
Yes.
That's a whole talk itself. Thank you.
A common problem that we are seeing more and more often. We know that these medications have lots of benefits, but as part of their mechanism of action, they are slowing down gastric emptying, and this does lead to a sort of downstream effect promoting reflux disease. In this scenario, what I will typically tell patients is that dietary modification, as they might already be doing, depending on how they've been instructed to take the medication, is actually really key. Eating smaller meals, perhaps eating smaller but more frequent meals, can be helpful. Oftentimes the benefits of these medications are very significant, and therefore managing their reflux disease with additional pharmacotherapy is often the approach that patients like to take. And so if dietary modification, specifically meal portion size, isn't enough, then I will talk with them in a similar way about whether or not we can have them on, for example, a PPI for a few months, especially while they're up titrating, say, their GLP-1 medication. Once they feel like they're at a steady dose and maybe have adjusted to the physiologic effects of that medication, we'll then try to remove the PPI and see how they do.
Thank you.
Dr. Pandya, are you all set?
Thank you, Dr. Reddy. Wonderful presentation. As a gastroenterologist, if I can highlight some of the points you made, one was as a primary care physician, if your patient has long-term GERD, particularly 3 to 5 years, screening for Barrett's esophagus, which could change the treatment or follow-up would be very helpful. Secondly, for every patient with dysphagia, difficulty in swallowing, again, further workup, including endoscopy, would be helpful in ruling out any strictures or neoplasm, but an eosinophilic esophagitis that is becoming more relevant now. The newer medications for acid suppression are good, but they're very expensive. So again, until the prices come down, PPIs will remain the mainstay because they do the job in most patients. And lastly, PPIs are best taken before the first meal because they block the H2 receptors or the proton pumps, which remain blocked for a number of hours depending upon the PPI. So I see many patients being advised to take the PPI at night, but at night we don't eat, so we don't make acid. So blocking the hydrogen pump is not effective. So I wanted to make those points. Thank you.
Very well said.
Any other questions or anything
Yeah.
else in the
Dr.
chat? Terry?
Singh, Dr. Singh, would you like to ask your question?
Yes, Dr. Reddy, I'm a family physician. I have a quick question. Does metoclopramide affect the lower esophageal sphincter in any way?
That's a great question. Unfortunately, it does not. We know that metoclopramide, which is the only FDA-approved medication for gastroparesis, promotes gastric motility, but it does not influence esophageal motility. It doesn't affect the lower esophageal sphincter as it might relate to achalasia or other conditions. And there are some motility disorders in which the esophagus is weak. And metoclopramide does not help with motility or peristalsis in the esophagus in those settings either. So to answer that question, no. From what we can tell, metoclopramide does not affect the esophagus.
Thank you, Dr. Reddy.
Any other questions?
Anything else in the chat, Mary?
No, nothing else in the chat, Dr. Moore.
Well, Dr. Reddy, thank you so much. This has been a great session, and thanks to everyone that that had questions and comments. It's greatly appreciated. We hope we will see you back on 9/11 for the next program we'll be doing. And we thank everyone for attending this evening. Dr. Reddy, thank you once again. Great job. And for everyone else, have a great evening, and we look forward to seeing you back very soon. Take care and good night. Bye-bye.
Thanks, Dr. Reddy.
Yeah, thank you so much for having me.
You're welcome. You did great.
Well, thank you. Yeah, if you have any feedback on the presentation, I welcome it and appreciate it.
Yeah, you'll get an evaluation from me. It closes on Monday. And so a couple days after that, you'll get a summary of all the comments and attendance and who was there, the audience makeup and all that. And also when you, it'll also give you kind of a description of what your check will look like when it comes in the mail. Because sometimes we get so much junk mail, you know, and stuff. So information about that as well. Sorry, that's like important to me. So yeah, but you did a great job, and thank you so much, and we'll see you next time, okay?
That sounds great. Thank you for the opportunity.
Bye-bye.